My name is John Ney, and I'd like to welcome you to a talk about the economic value of the Ceribell Rapid EEG device. First, a few words about myself. I'm a neurologist, a health services researcher, and I focus on cost-effectiveness analysis and large data set analysis. I'm faculty at Boston University School of Medicine and adjunct faculty at Indiana University School of Public Health and School of Medicine. I'd like to start by talking about value. Healthcare, like any business, is concerned with the allocation of finite resources. There's only so much money to go around, and we need to decide what's the most appropriate treatment for our patients and what is ultimately the most cost-effective treatment. So when new interventions are created, these should be evaluated relative to standard care. And to be adopted, new interventions need to be evaluated both in their effectiveness in improving health, but also the cost to the patient and to the healthcare organization. Value addresses both costs and health outcomes. Having discussed value, I'd like to move on to the Ceribell Rapid EEG device. This is an 8-channel EEG. It is quickly applied, does not require an EEG technologist in order to apply it correctly, and is designed for use in inpatient and emergency room settings. It consists of a headband, as well as a visual electrographic and sonification output device. It can transmit via Wi-Fi to the cloud for real-time interpretation or for post-hoc evaluation of EEG tracings. The Ceribell Rapid EEG device was evaluated for its diagnostic properties via the Bedside trial. This was a 5-site trial and involved neurology residents and fellows in order to apply the device in the absence of EEG technologists. The cohort of interest was individuals with suspected non-convulsive seizures. All users of Rapid EEG were asked for their clinical suspicion prior to applying the Rapid EEG device. In other words, what is the likelihood that this patient with suspected non-convulsive seizures actually has them as compared to what the Rapid EEG device results would say. All patients ultimately received conventional EEG. The Decide trial had 164 patients. They averaged close to 60 years old. Most were male. Notably, the time to acquisition of Rapid EEG was 5 minutes on average in comparison to conventional EEG, which was nearly 4 hours. The diagnostic properties of Rapid EEG showed marked improvement over clinical suspicion, being 100% sensitive and 89% specific, as opposed to clinical suspicion alone, which was 78% sensitive and 64% specific. So the Decide trial showed us that highly accurate diagnostic information can be acquired quite quickly in the absence of an EEG technologist and without conventional EEG. So how does this lead to improved costs and improved outcomes for our patients? And the answer to that is relatively simple, that the Ceribell device reduces decision uncertainty in treating non-convulsive seizures. Whereas conventional EEG may be delayed by hours at a time, Rapid EEG can be acquired in just a few minutes. The time that would be spent waiting for routine EEG is time that clinicians may use to treat the patients, and that can lead to unnecessary treatment if they're not actually having seizures, and that can lead to increased costs, both for intubation, for parenteral anti-seizure medications, and for prolonged mechanical ventilation. Also, the opportunity for early seizure termination with benzodiazepines without having a EEG to verify whether or not the benzodiazepine treatment is working may simply not be feasible. Ceribell Rapid EEG therefore provides more decision certainty in a very quick time frame compared to conventional EEG. To quantify the economic value of the Ceribell Rapid EEG device, we built a decision model, and that model was based off of a cost-benefit framework where all the outcomes ultimately are monetized. We looked from the perspective of the hospital system. The time frame of interest was the beginning of the admission until the discharge of the patient. We did not include long-term costs. We did not evaluate the cost post-discharge nor any pre-admission associated costs. The condition of interest was non-convulsive seizures and suspected non-convulsive seizure. We compared Rapid EEG versus clinical suspicion, as was done in the Decide trial, using Decide trial data. The structure of the model was a tree as opposed to a Markov model, and we conducted uncertainty analysis with probabilistic sensitivity analysis and one-way factor analysis. This is the structure of the decision tree. So we start with patients who have suspected non-convulsive seizures, and then at the decision node, we decide whether or not to use rapid EEG or just to rely on clinical suspicion alone. At the next event node, either a patient does have seizure or does not have a non-convulsive seizure. And if they do have a non-convulsive seizure, it can be either detected or undetected, producing a true positive or a false negative. If they don't have a non-convulsive seizure and one is detected, this is a false positive. And likewise, if no non-convulsive seizure is detected and this was a situation where non-convulsive seizure did not occur, this would be a true negative. The same would be the case in the no rapid EEG, aka clinical suspicion only arm. And the major difference then follows in patients who are true positives and non-convulsive seizures are detected, they would be candidates for early termination of seizure with benzodiazepine medications. So now we're going to talk about the model parameters, and these include probabilities, length of stay information, and costs. The likelihood of a non-convulsive seizure when one is suspected was 21%, and this was from 4 different studies that were pooled together. The diagnostic properties of rapid EEG and clinical suspicion have already been discussed and were taken directly from the Bedside trial. We looked at early seizure termination from a paper in 2016. And length of stay was determined from the National Inpatient Sample 2017, looking at patients with coma who were treated for seizure versus actually given a diagnosis of seizure. We also modeled the proportion of time that a patient spent in the ICU and the reduction in ICU stay that's attributable to early seizure termination. The costs are all 2019 costs, and this includes the additional daily cost of mechanical ventilation on top of hospitalization, which is quite substantial, nearly $2,000, the cost of intubation, and parenteral anti-seizure medications. So the results of the model at the reference case are that the Ceribell rapid EEG device, relative to clinical suspicion, saves $4,000 in total hospital costs, 1.2 days in length of stay, reduces ICU length of stay by 0.4 days, and also reduces the likelihood of unnecessary treatment by roughly half. This graph depicts the probabilistic sensitivity analysis, which is a Monte Carlo simulation that includes 1,000 replications, and of those, the vast majority showed cost savings that favored the rapid EEG device over clinical suspicion alone. Notably also the mean difference in cost, because we used a probabilistic analysis and costs are not distributed normally, was greater than what was shown in the reference case analysis. Here we have a one-way factor analysis that looks at the influence of particular model parameters on the outcome of the difference in total hospital costs between individuals receiving the rapid EEG device versus clinical suspicion alone. And we can see that anything that leads to unnecessary treatment or exacerbates the effects of unnecessary treatment, and these would be the specificity of clinical suspicion, rapid EEG, or the false positive rate, are going to have a considerable influence over the ultimate outcome. Less so for cost per day of hospitalization, the probability of early seizure termination, although that's still quite substantial, and the true positive length of stay patients. The incremental cost of daily mechanical ventilation is also important, but less so than some of these other factors. So in summary, the Ceribell rapid EEG device saves almost $4,000 in total hospital costs relative to clinical suspicion alone, and with less unnecessary treatment as the primary driver. And this leads to shorter lengths of stay, shorter ICU stays, and fewer unnecessary intubations and treatments with parenteral anti-seizure medications. Models most sensitive to false positive rates, and further research and modeling should characterize the benefits that occur after hospitalization, and these include issues such as quality of life and healthcare utilization following hospitalization. If you're interested in further details of this analysis, it was published in the Journal of Medical Economics in January of 2021, and it is available free online. Thanks again for your attention, and have a good day.